Okay, well, welcome to the WPS GHA Contractor Advisory Committee meeting. Today is October 26th, 2023, and the time is 6:07 p.m. My name is Dr. Jody Sangstock, and I'm the CAC rep for Michigan representing podiatry. And I'll be moderating the meeting today along with my CMD co-chair, Dr. Joelle Velakis. The purpose of the CAC is to present the draft LCDs up for consideration and to take comments from the CAC. The public is welcome to attend in the listen-only capacity. Your attendance as a CAC member at this meeting implies that you consent to the public disclosure of your opinion and agree that it may be used and will be clearly identified as your opinion within the proposed or final draft LCDs discussed. If a CAC member does not consent, please disconnect now, as the meeting will be recorded and transcribed. To aid in transcription, before you make any comments, please state your name and any conflicts of interest you may have, or state that there are none. Individuals wishing to comment may click on the raised hand icon. Press *3 if you're attending by phone. When Mr. Stanley calls on you, please make sure that your microphone is on at your end and that your speakers are silenced to prevent an echo. CAC members should follow up on any verbal comments in writing to Medicare Policy Comments at WPSIC.com. Now I'd like to turn over the meeting to Dr. Velakis.
Thank you so much. We're going to begin by talking about our draft local coverage determination or LCDs. I am Dr. Joelle Velakis. I am a contractor medical director with WPS, and I'm delighted to be with you this evening. So we'll start with our first. Let's just let you know all of these have open comment period from September 28th until November 11th. Comments won't be addressed individually, but will be compiled and addressed in a response to comments document posted with the final LCDs. Please remember, you would do us a great kindness and favor if you would follow up any verbal comments this evening with a written response to us at Medicare Policies Comments at WPSIC.com, and that is also listed for you for convenience on our landing slide. So our first draft LCD is DL39720, molecular testing for risk stratification of thyroid nodules. This is new. This is being shepherded by our very capable CMD, Dr. Denise Nishatsky, and our policy coordinator on this draft is Emily Zahner. So this, in summary, I'll just give you very briefly, it is a criteria for which WPS will cover molecular diagnostic tests for use in a beneficiary with an indeterminate or suspicious thyroid nodule. And this is dependent a good deal on Bethesda categories. And I think that crux of this is that the results of the test will be used to aid in decision making. There are some details which I think will defer at this time, but that is the summary. I'd like to open it for CAC member comments and or any requests for me to read in toto.
Okay, and CAC members, you should not need to press the raise hand icon. If you can just unmute yourselves if you're on the panelist. It appears we have no comments on this draft.
Thank you, Rich. Our second draft LCD for reconsideration is bisphosphonate drug therapy. This has been shepherded by Dr. Denise Nichowski and Emily Zanger, our policy coordinator. This draft LCD is a reconsideration of coverage and expands the indication for IV bisphosphonate treatment for things such as post-glucocorticoid-induced bone loss in transplant recipients and the like. I'd like to open for comments. Okay, I'll move on to our next trigger point injections. This is DL 39713. This has been written by Dr. Robert Kettler with our policy coordinator, Michelle McCary. In essence, it addresses when trigger point injections will be considered reasonable and necessary. It identifies considerations for initial trigger point injections, subsequent trigger point injections, as well as frequency of those injections, and also suggest initial treatment options prior to trigger point injection. Any comments from our CAC members? Okay, I'll move on. Our next LCD on the docket is DL 39709, our MolDX gene expression profile for decision-making in castration-resistant and metastatic prostate cancer. It's the responsibility of our policy coordinator, Melissa Leitz, with our CMD, writer, Dr. Denise Nichowski. This coverage policy is for gene expression profile tests that assess risk and predict therapeutic response in men with an established diagnosis of castration-resistant or metastatic prostate cancer. This is considered testing that's reasonable and necessary to help guide treatment decisions in men with prostate cancer, which includes an opportunity to discern life expectancy such that more reliable and reasonable treatment options can be discussed. And I'll leave it open for comment.
Yeah, Brad Orris, I'm a urologist in Indiana, and I would speak in favor of this. I agree with the LCD.
Thanks so much.
Can I ask how you're going to use that in, this is Joe Moscato, use that in terms of the standard sort of prognostic indicators? Can you explain that a little bit more and how you would do it if there's discordance?
Is that question for me or for the moderators?
For you, I'm sorry, as a urologist.
Yeah, so the Decipher test has been used just as a way of looking at the genetics of a cancer versus simply the Gleason score, which is a fairly crude, just pathologic analysis. And so the Decipher score can tell us whether it's going to respond to androgen deprivation or some of the newer therapies that are available. And the data for it is outlined in the LCD. Some of the more recent trials that have used the Decipher and its ability to assess response to therapy.
I'd like to thank you so much for offering your urologic advice in regards to that. It's much appreciated.
Yeah, thank you both for the discussion. Any other comments? All right, let's move on to LCD DL 39711, molecular biomarkers for risk stratification of indeterminate pulmonary nodules following bronchoscopy. We have our CMD, Dr. Denise Nachowski, and Policy Coordinator Melissa Leitz on this. I just want to point out that November is Lung Cancer Screening Awareness Month. Certainly, since I've been in practice, there has been a absolute increase in understanding and knowledge about how to manage these, but also puts us in a complexity that's new. I congratulate Dr. Nachowski for suggesting limited coverage for molecular tests to aid in diagnoses and our exclusion of lung cancer in patients with an indeterminate pulmonary nodule following a non-diagnostic bronchoscopy. Many of us are familiar with those, especially when all other conditions are met. There are a number of these, but I'm going to pull out some of the more, I think, things that are very germane for this discussion. Rule-out tests should have a high sensitivity and negative predictive value such that patients can be safely selected for a less aggressive management strategy without delay to diagnosis due to false negative results. And then rule-in tests should have a high specificity and positive predictive value such that patients can be safely selected for more aggressive management without significantly increasing procedures in patients without cancer due to false positive results. This is very well done, very well thought out, and I'm interested in comments from our CAC members. Okay, I'll move on to our next. DL 38680, molecular testing for solid organ allograft rejection. And this is our policy coordinator, Melissa Leitz, with our CMD, Dr. Nachowski. This provides limited coverage for molecular diagnostic tests used in the evaluation and management of patients who have undergone solid organ transplantation. These tests can inform decision-making along with standard clinical assessments in their evaluation of organ injury for active rejection. This is a revision for clarity and coverage criterion. There's no change in coverage from the current policy, but subject matter experts supplied support and weighed in for use of these molecular tests in kidney allograft patients, heart and lung transplant patients where rejection is expected, but for whom obtaining a biopsy may be problematic. Welcome your comments at this time. Okay, we will move on to our next LCD, which is special histochemical stains and immunohistochemical stains. This is our policy coordinator who ushered the leads, and our CMD is Dr. Jill Sumfest. This identifies medically necessary criteria for the use of special stains and or IHC stains. Additionally, the policy addresses, based on claims review, the scenarios that may be driving medically unnecessary overutilization or incorrect billing of these services. We have a formal presentation for this draft LCD. I'd like to introduce CAC member Dr. Vashahali Pansare, who will present on this, and I'd like to thank her for her presentation ahead of time. She was able to share with us on our open LCD meeting yesterday, and I know you all will appreciate what she has to say in her presentation.
Thank you, Dr. Vlahakis. I hope you can hear me.
Yes, we can. Thank you.
Okay, great. Thank you. Okay, so my name is Vaishali Pansare. I'm a pathologist in Southeast Michigan. Currently, I function as the Chief of Pathology at Corewell Health, which was formerly called as Beaumont, Troy, and Grosse Pointe. And I'm also the genitourinary pathology system lead for Corewell Health East. I'm here to present the immunohistochemical stain requirements for prostate cancer diagnosis and prostate core biopsies. Next slide, please. And I have no financial relationships to disclose. Next, please. So before I go into the LCD statements themselves, I want to talk about a little bit about NCCN risk categories or National Comprehensive Cancer Network risk categories for prostate cancer. I know we have a urologist on the call here today. So NCCN is widely used by many urologists across the country, and the risk categories are basically divided into 5 groups based on certain clinical pathologic characteristics. The 5 groups are very low risk, intermediate risk, high risk, and very high risk. I have highlighted certain things that are related to this LCD. As you can see, in the very low risk, we have a patient who has less than 3 biopsy cores that are positive with less than or equal to 50% cancer in each core. In the intermediate risk category, we have Gleason score 7 and less than 50% cores involved would fall in an favorable intermediate risk category, whereas unfavorable intermediate risk is a grade group 3 or 4+3 cancer with more than or equal to 50% cores involved. High risk involves Gleason score 8 to 10, and very high risk, I want to just point towards the statement that says tumor volume on the biopsy is important for very high risk. Next slide, please. So based on the risk categorization for each of the patients management is different. So this risk stratification helps us determine the prognosis and treatment therapies for these patients. It ranges anywhere from active surveillance, probably in very low risk patients, to brachytherapy, external beam radiation therapy, and then finally radical prostatectomy and radical prostatectomy with lymph node dissection for high risk patients. Next, please. So the LCD statement that says it is not reasonable and necessary to bill for immunohistochemical staining in a negative or a suspicious core biopsy when an obvious prostate cancer is present in other cores. So I'm going to present 3 different examples here. The first example is a patient who has a Gleason 3+3 = 6 in 2 of the 12 or 13 cores that were submitted to the pathologist. That patient is now in a very low risk group and could get active surveillance. If it is a 3+3 = 6 cancer in 3 of the 13 cores, the patient would then fall in the low risk category. Patient who has a Gleason score of 3+4 = 7 in 6 of the cores is a favorable intermediate risk group, whereas if there is one more additional core that has 3+4 = 7, that would be an unfavorable intermediate risk group. Next slide, please. So additionally, if we look at the laterality of the prostate, so we typically get 6 cores from the right side and 6 from the left side, and sometimes a targeted 13th core. So if there is Gleason score 3+3 = 6 in 3 cores on the right side, the patient would be a low risk group. But in addition to these, if there is 1 core on the left side, that would make the patient favorable intermediate risk group category. Next slide, please. So the next LCD statement is for prostate cases when immunohistochemical stain workup is not reasonable and necessary, includes When there is a multi-part biopsy with 3+4 cancer in one part and atypical small SNR proliferation or ASAP suspicious for 3+3 cancer in other part. So atypical small SNR proliferation is basically small tiny glands, a small focus of small tiny glands that are suspicious for cancer, but as a pathologist, I'm not 100% sure it's carcinoma or not, and I have to do immunostains for this. What difference does it make if there's already 3+4 in one part? So if there is 3+4 equals 7 cancer and 6 cores, the patient would be in a favorable intermediate risk category. Now, if there is an additional core that has this ASAP and I did an immunostain and it proved to be a Gleason 6 3+3 core, 3 cancer, then the patient would then move into an unfavorable intermediate risk group. Next slide, please. And the last LCD statement was about immunohistochemical stain is not reasonable and necessary in a multi-part biopsy when the cancer is actually 4+3 equals 7 in one part, and there are atypical cribriform glands in another part. When there are atypical cribriform glands, to a pathologist, the differential diagnosis is between an intraductal carcinoma of the prostate, which is carcinoma just limited to the duct, or an invasive Gleason 4 pattern carcinoma. The difference is that if there is a 4+3 equals 7 in one core and an intraductal carcinoma in one core, the patient is a favorable intermediate risk group category. However, if this focus after performing immunostains turns out to be an invasive Gleason 4, we have to classify it or grade it as a 4+4 equal to 8 cancer in that core, and then that patient becomes a high risk group by NCCN guidelines. So as you can see, all the immunostaining that we would do to confirm malignancy in these foci would have a really major impact on patient management, and knowing how many cores are positive, what grade they are, and what percentage of each core is involved is critically important for the pathologists and obviously for the patients. So in summary, I would like to ask to allow coverage of these very important immunostains by removing those 3 statements. The first one was related to immunostains in a suspicious core when there is obvious prostate cancer in another core. The second one was with the 3+4 7 in one part and atypical small SNR proliferation in another part. And the last one was this one, the 4+3 in one part and atypical cribriform glands in another one. Thank you for your time.
Thank you, Dr. Pansari. I really appreciate the effort that you put into putting this together for us, and want to remind everyone on the call that the input that we have from our CAC members and our physicians in our jurisdictions really elevates what we're able to do with these LCDs. So the thought and the planning that you put in, we really appreciate.
Thank you.
So any further comments or any questions for Dr. Pansari? And I'll remind you also, when you do comment, if you can make sure that you also write a summary and post it to policies, comments at wpsic.com. That'd be terrific.
Just a question. This is Joe Moscato again. Just a question about, so the question is, when are the pathologists sort of allowed to do this staining? And, so much of it is a judgment call to say this will change the prognostic staging. Is that the way sort of the LCD is reading? I mean, because how much leeway are you given? So I'm just wondering, because it sounds like the real pathologist really is the position to know this, to say, I have to make a decision in terms of grade or prognostic category, and I really need this information. And are you prevented from billing for that? That's my question.
Sorry, the way the LCD statement reads is that we could do the stains if you wanted to, but it is not reasonable, so we will not get paid for the stains that are performed.
Sounds wrong to me, but that's my opinion.
I agree. Thank you.
This is Brad Orris again. There's really in reality 6 grades in the NCCN, not 5, because the intermediate is, as you can see, separated into favorable and unfavorable risk. And the difference is if they choose to get radiation in the favorable risk, they would just get radiation alone. In the unfavorable, they would get 6 months of androgen deprivation in addition to the radiation. So it's really a big difference trying to decide 3+4 or 4+3 and whether they're favorable or unfavorable risk. So this is not trivial stuff that we're talking about here. So I agree with the pathologist that if they need the stains to make that determination, it makes a big difference on a patient's treatment, whether or not they have to get androgen deprivation or some other increase in their amount of therapy based on their NCCN category, which is truly what we use all the time for treatment choices.
Wonderful discussion. Appreciate it. Anything further before we move on to the next?
Hi, this is Rich, the Policy Administrative Assistant. I just want to remind, I know there are some CAC members who may only be on the telephone line due to commuting. They would still have to press *3 if they would like to make a comment. So if anyone is out there feeling muted, just press *3. Thank you.
Okay, I will move on to implantable continuous glucose monitoring.
This is
Yes.
Dr. Craver, if I can still speak on the last LCD. Yeah, it's Dr. Craver. I'm Jeff Craver. I'm a pathologist from Missouri, medical director at St. Mary's Hospital, Michigan Heights, member of the Missouri Society of Pathologists, and I really appreciate Dr. Consari speaking in such a brilliant way, and I appreciate her PowerPoint presentation. I also listened to the open meeting yesterday, and Dr. Lowski presented also another very good rationale for how special stains are very useful for classifying different genitourinary tract cancers. And it's important to use a select panel of stains to accurately classify tumors. With the World Health Organization putting out so many tumors years, including the various new ones discovered when you add in various molecular classifications of tumors, it helps determine how difficult or how some tumors may respond better to treatment and some may not need treatment at all. So it's very imperative that we use the appropriate tools to make the right diagnosis. And also, there are additional categories addressed in the LCD that were not addressed in particular on this call, but I do know that the Council of American Pathologists is working on a letter that will address many other body types and tumors that are covered by this LCD, and we're hoping that if the MAC, the J5, J8 MAC reviews that letter, they'll find additional opportunities to revise the current LCD. Thank you for your time.
Thank you, Dr. Graver. Really appreciate your comments yesterday and today.
You're welcome.
Anyone else? I hate to interrupt such a great discussion, but I will move on to the next one. That's DL38686, implantable continuous glucose monitors. This was also ushered in by our coordinator, Leeds, and our CMD, Dr. Juan Chaney. It modifies the coverage criteria for implantable continuous glucose monitors based on the best available evidence. As you all can imagine, medical devices, class 3 medical devices that require pre-market approval by the FDA can make decisions about what's considered reasonable and necessary, a moving target. This expands the indications for implantable glucose monitoring to replace finger stick blood glucose measurements for diabetes treatment decisions. I'd like to open it for CAC member comment.
Rob Jackson, I'm a family physician, no conflicts of interest. I just wonder about these devices. We have the external monitors that are finicky at best. They are very helpful in managing diabetes and giving patients feedback about where their blood sugar is so they can intervene, so they can change their lifestyles and so on and so forth. But having seen the external devices, I have some questions of whether we're jumping into something that's not ready for prime time. That's all. So I'm a little bit. It's not something right now that I want one of my patients to get. I imagine headaches for them and me. And the external devices work so fairly well. If it's not working, you can just change the sensor. So this is probably more of the, we all like bells and whistles. That's all. Thanks.
Thank you for your comments. Any others? All right, so I will describe our last LCD for comment. DL39716, cataract extraction. Policy coordinator is Michelle McCary, and our CMD is Dr. Jill Sumfest. Medicare coverage for cataract extraction and cataract extraction with intraocular lens implant is based on services that are reasonable and necessary for the treatment of beneficiaries with cataracts. This policy defines coverage and describes criteria necessary to justify the performance of cataract extractions, including the use of visual acuity scoring. I'd like to open it up for comment.
This is Matthew Appenzeller, ophthalmology, Omaha, Nebraska, CAC. I guess you would say I might have financial interest because I do occasionally do cataract surgery, but I am actually mainly a retina specialist. There's been a lot of discussion about this proposal in our community. I can point to two very specific concerns about the exact proposal. There is a significant concern over identifying a numerical line in the sand, that we are trying to apply a quantitative measure to what is effectively a qualitative issue. I can point to many times in my career where patients have had significant impacts on activities of daily living with visual acuity scores best corrected with glasses to better than 20/50, but they are adamant that they cannot perform at work, or that they cannot feel they cannot drive safely, and have handed over driving to family members, which puts added pressure and economic burden on their families. I even had a patient today who came in with a huge bandage on her leg because she had tripped and fallen due to poor depth perception, where she maintains 20/40 vision in one eye and 20/25 in the other. And, depth perception is created by having good vision and relatively equal vision in both eyes. This is a patient who, under this LCD, even though she has been injured, would still not qualify under this LCD. So again, I have some significant concern about applying a quantitative measurement to what is a qualitative disease affecting quality of life. The second one, speaking specifically, is that I am a retina specialist, is the requirement in this LCD that states that other eye diseases, including but not limited to macular degeneration or diabetic retinopathy, have been ruled out as the primary cause of decreased visual function. I see a lot of patients with diabetic retinopathy, macular degeneration, retinal venous occlusions, who have vision that is definitely poorer than the 20/50 mark that is being identified here. However, they also have very, very significant cataracts. Under this LCD, I can still see into the back of the eye, so that, the criteria of an unimpeded view would not qualify. It does not interfere with any type of surgery. It does not they do not have intolerable anisometropia. But I know for a fact, because I've been there before, where these patients, when we remove their cataracts, they may go from 2400, 2200 vision to 2080, 2070 vision. And please understand, these patients come back literally crying in my chair about how much better things are and how much of an impact it's had on improving their quality of life, that they now can read where they couldn't read before. And this LCD would stop that from occurring. So I encourage the medical directors to revisit this LCD and really take a very hard look at removing those two qualifications, one of ruling out retinal disease as a primary cause and removing any numerical quantitative measurement regarding this qualitative disease. That's it. Thanks.
Thank you so much for your comments and your experience. Any others?
Yes, this is Dave Volman. I'm the ophthalmology CAC representative from Missouri. No conflicts of interest. I just want to echo what Dr. Appenzeller spoke to in his experience. I was also able to join the open meeting yesterday and thought that Dr. Woodward's presentation on how the Snellen visual acuity measurement does not capture the total qualitative impact to patients was very well done. And I just recommend for the medical directors to really take that under consideration. Again, as you think about this LCD, the patients who have the impact to their activities of daily living do not always, as Dr. Appenzeller said, meet that threshold of 20/50 visual acuity on a Snellen eye chart, but can have significant inabilities to drive themselves to their appointments, to effectively use their medications, and to basically deny medically necessary care in order to allow our patients to care for themselves based off a numerical cutoff. Seems not the right method to go about doing that. Also, just for awareness, this would be the first MAC that would use any form of Snellen visual acuity cutoff as in their LCDs for determining the medical appropriateness of cataract surgery. So I think all of those things need to be very significantly factored in and considered as this draft LCD is reviewed.
This is Matthew Appenzeller again. May I make one more short comment?
Please.
Just very quickly, there is, and I will upload this information to the policy comments. There is also data pointing to other comorbidities, or not comorbidities, but more morbidities that can occur due to the reduction in the quality of vision that is created by the cataract, regardless of posterior disease. And that, including things like, there was a good study looking at the frequency of hip fractures and things like along those lines. So again, I will identify those studies for you, upload those into the policy comments. But again, it's one of those things where this is I reiterate that this is a quality of life issue, and having a numerical cutoff makes it very, very difficult to incorporate the entirety of the patient experience in order to improve their lives.
Thank you so much. And you actually answered a question I had for you. Any articles that you can submit for us exactly as you described will be exceptionally helpful. And thank you very much for your generosity with that. We had a very helpful presentation yesterday from Dr. Woodward, and we'll follow up with any of the articles that you're able to send to us. Any other comments?
I see that Dr. DiLorenzo has unmuted her mic, but I'm not hearing her. Do you have?
Yeah, hello.
There you go.
Can you hear me? Say hi. So I also would like to, hi, I'm Louisa DiLorenzo, Michigan Society of Eye Physicians and Surgeons, J8 CAC. I also would like to echo what Dr. Appenzeller and Dr. Volman have mentioned. I'm a general ophthalmologist. I do cataracts as well as other treatments and procedures. And, I have concerns as well about this rigid 20/50 stipulation. I know that when we decide with a patient and we decide together whether they need cataract surgery, they always emphasize to me, what are your limitations for your activities of daily living, driving, reading. And so, I feel it's very limited using a numerical evaluation of visual acuity because it doesn't reflect their functioning. And that is, we aim as physicians to improve quality of life. And so again, I would ask that 20/50 stipulation be reconsidered. And thank you.
Thank you, Dr. DiLorenzo. Any others?
I don't know if you all can hear me as well. I'm Ann Krafzig. I'm ophthalmologist in Fort Wayne, Indiana, with the Indiana Academy of Ophthalmology. And I just wanted to kind of echo all of these other sentiments. I think it's the impact on quality of life can vary significantly, and what for one patient might feel like a huge impact on quality of life is sort of different for another patient given their home life and circumstance. And I agree that having that fixed 20/50, it seems like that would not allow a lot of patients who are having trouble to access the care they need. So I agree with all the other comments as well.
And we'll just ask everyone to remain on mute unless they're speaking. And thank you all for the comments. I'll remind you, all of those of you who had something to contribute today, or if you were too shy to contribute today on the call, please do send your comments to policycomments@wpsic.com and let us know. And with that, I'm going to hand the meeting back to Dr. Sangstock.
Thank you very much. This concludes the presentation and discussion of the draft LCDs. I'd like to thank the public for attending, and you may disconnect now. After a moment, we will continue with the CAC members only portion of the meeting where we will discuss contractor updates, projects, and provider engagement.